Great evening, everyone. I'm Dr. Asim Lashin. I am going today to present the evidence of lung ultrasound use in the neonatal period. I have nothing to disclose in this presentation. I have two objectives in this presentation. The first, to demonstrate the best available evidence of lung ultrasound use in the newborn. I will follow this with few review questions at the end of my presentation. Here we can see the different uses of lung ultrasound, which I believe it was covered very well by other presentations from our colleagues, but I just enumerate here the words which I used during my search about the evidence of use of the lung ultrasound. And to do this, I formulated answerable clinical questions according to the evidence-based system using the PICO system, P-I-C-O, Patient Intervention Comparison and Outcome. You will find most of my evidence project and studies from the neonatal period, but some of them also came from the pediatric age group as well as few from the adults too. I did a PubMed comprehensive search. I found around 5 systematic reviews, 5 meta-analyses, 10 prospective studies, 2 retrospective studies, and included also 10 other studies, including our studies carried out here in Manitoba Center. I would like actually to start with this, to start with our work here in Manitoba Center, which has special interest with the lung ultrasound practice and research. In 2017, Yasser Sayed and his group studied a model of integrated lung and focused heart ultrasound as a new screening examination in infants at risk of respiratory or hemodynamic compromise. And in this study, they didn't only validate the use of the lung ultrasounds in cases of neonatal respiratory distress or hemodynamic compromisation, but also they studied the training module, which validated in this study to be enough for any participant, neonatologist, respiratory therapist, even nurses, residents, and others to practice the lung ultrasound. They exposed those participants, which was around 12 participants, for 2 days hands-in workshops, and they did around 12 cases of lung ultrasound. Then they asked those participants to have around 20 cases, 10 of them is abnormal with abnormal finding within a specific period of time. I think it was 3 months of period. Then if they finish this course and this number of studies, this will be a validated module for training to gain the required experience and skills to practice the lung ultrasound in your unit. In 2018, we found also Muhammad Abdel Maula and his group. They started to study the lung ultrasound score as early predictor for chronic lung disease in preterm. He retrospectively divided 2 patients for the prematures who developed bronchopulmonary dysplasia and who didn't. They compare the lung ultrasound score, which interestingly and significantly was higher in the bronchopulmonary dysplasia group in comparison to the normal babies group. And this was, I believe, one of the very early studies which went to this area prediction of bronchopulmonary dysplasia using the lung ultrasound score. In 2019, Dr. Deepak and his group also, they did and they published interesting project. They compare the position change, how it will affect the lung ultrasound scores. And in this study, they did 3 lung ultrasounds. The first one was called immediate lung ultrasound, which was done in whatever position the baby has. Then they changed the position immediately, and they immediately repeated the lung ultrasound. And they repeated also again for the third time after 1 hour. And they found the position change will change the lung ultrasound score immediately, but after 1 hour, the score will be similar to the immediate first lung ultrasound score done. They validated also the use of the lung ultrasound as a diagnostic and the follow-up module of neonate with respiratory distress. And I mean with the respiratory distress here, not only the respiratory distress syndrome, but the TTN and maybe other respiratory causes of respiratory distress. In 2020, Dr. Yasser and Dr. Shamla in our animal lab here in Manitoba University, they studied a model for lung ultrasound as early predictor for the histological lung injury in a neonatal model of acute respiratory distress syndrome, and they proved the use of lung ultrasounds for study this age group. Finally, we have still a current prospective project which carried out in association with the Mount Sinai Hospital in Toronto. And we are studying again as a prospective study the use of lung ultrasound score as again a predictor of bronchopulmonary dysplasia, which I believe it is a hot topic now for the research. Our research is one of them, and I believe there is another study published already maybe a few days back from Italy, proved also the use of lung ultrasound score as predictor of bronchopulmonary dysplasia. What about the systematic reviews? I will highlight here the importance of this interesting systematic review, which carried out by Hiles and his group in 2017. They studied actually the comparison between the chest X-ray and the lung ultrasound as a module of diagnosis for the neonatal respiratory distress syndrome. Again, they did a systematic search from 1990 till 2016, and they identified relevant 6 studies, met the review inclusion criteria, and were retried for analysis. Those studies included around 480 units. And they concluded that the lung ultrasound was highly sensitive for the detection of the neonatal respiratory distress syndrome, although they give some alarm about the potential miss of some pneumothorax and ear lake syndrome, which personally I believe this was improved dramatically during the last few years. Again, Razak and Fadin in 2019 in Saudi Arabia, they did another interesting systematic review for the neonatal lung ultrasonography to evaluate need for surfactant or mechanical ventilation. So here in this study, they used the lung ultrasound score as indication or a parameter for using the administration of surfactant or connecting our babies to the mechanical ventilation. They did a comprehensive search from inception until October 2018. Again, they concluded that the lung ultrasound, particularly the score, can be used accurately to determine the need for surfactant replacement, treatment, or mechanical ventilation in infants with respiratory distress syndrome treated with CPAP. The accuracy, interestingly, and the very important note here, the accuracy is better in younger preterm infants compared with late preterm and term infants, and this is the most vulnerable age group we are facing in our daily practice. Again, in Australia in 2019, we can find also they assess the tools to assess lung aeration in neonates with respiratory distress syndrome. And this was a systematic review published on between January 2004 and August 2019. This group, they didn't recommend any specific module in the diagnosis of RDS and TTN, but they validated the use of lung ultrasound like other modalities like the chest X-ray or other modalities to diagnose the RDS. Finally, I have an adult meta-systematic review, which was done by Leonard and his group to use the lung ultrasound as emergency diagnosis of traumatic pneumothorax and hemothorax, and this confirmed the use of chest ultrasonography has good diagnostic accuracy for traumatic pneumothorax and hemothorax in adults. It seems to be a valuable adjuvant tool in the emergency diagnostic approach of these patients. And from Saudi Arabia again, in adult group also, Khalid al-Rashi informed or confirmed the same findings by testing the characteristics of ultrasonography for the detection of pneumothorax, a systematic review, and again, performance of ultrasonography for the detection of pneumothorax is excellent and is superior to supine chest radiography. From the meta-analysis point of view, we have one from China, is lung ultrasound useful for diagnosing pneumonia in children? This was a meta-analysis carried out in China, and they concluded that the current evidence supports lung ultrasound as a useful imaging alternative for the diagnosis of a childhood pneumonia that is easily carried out, readily available, relatively inexpensive, and free from the hazards of radiation, and it makes it an attractive alternative to chest radiography and the physical examination for the diagnosis. In United States of America, 2015, we have almost similar meta-analysis, studied the lung ultrasound for the diagnosis of pneumonia in the children again, and they concluded current evidence supports lung ultrasound as an imaging alternative for the diagnosis of childhood pneumonia. They recommended clearly also to train pediatricians on lung ultrasounds for diagnosis of pneumonia, which may have improvement implications in different clinical settings. Another lung ultrasound for the diagnosis of pneumonia in adult group, and they concluded the same conclusion and evidence. Some of the very important prospective studies, which published very recently in July and August 2020. The first one of them came from Javier Rodriguez and his group, and it was a randomized controlled trial to study the early surfactant replacement guided by the lung ultrasound in preterm newborns with RDS. It's called the ULTRA-SURF randomized controlled trial. This investigates whether using lung ultrasound score in premature newborns with respiratory distress syndrome allows for earlier surfactant therapy within the first 3 hours of life in comparison to using the current modality of FIE2 criteria. In this study, you can see here, they divided the preterm less than 32 gestational age with respiratory distress into 2 groups. One group called the ultrasound group, and the other is a control group. The control group, they received the standard of care, which doing now currently, and they divided the babies according to the gestational age, more than 29 and less than 29 weeks, and used the FIE2 cut level of 30 if less than 29 weeks, and 40 if more than 29 weeks. Those patients who had FIE2 in this limit, they received surfactant. And those who are not, they didn't receive surfactant. While in the ultrasound group, they used the cut limit of lung ultrasound score 8 as a cut point for surfactant administration, regardless of the FIE2. So if the lung ultrasound score RDS more than 8 independently FIE2, they will give surfactant. If the lung ultrasound score less than 8, they will go for the same arms like the control group, depending on the gestational age as well as the FiO2 level, they will give surfactant or they will not give it. And they concluded at the end of this interesting recent study that the lung ultrasound score allowed an earlier surfactant therapy, reduced oxygen exposure early in life, and a better oxygenation after the treatment. This early surfactant replacement may lead to reduced oxygen exposure. Another very interesting study came from Francisco and his group in July 2020 and published in the European Journal of Pediatrics. Again, they studied the lung ultrasound guided surfactant administration time for a personalized physiology driven therapy. It's called ETHER study, ESTHER, echography guided surfactant therapy. When surfactant is given based on lung ultrasound score versus the oxygen requirements, they found that more babies received surfactant within 3 hours of life with less oxygen exposure. Interestingly, this reduced oxygen exposure but did not change the overall surfactant use. Now I'm going, after this short journey for the evidence of the lung ultrasound, I'm going to give just few or two refreshment questions. The first question for me, you can choose the best answer or answers. Question number one, according to Francisco RCT, it's called ETHER study. When surfactant is given based on lung ultrasound score versus the oxygen requirement, this leads to A, overall reduction of surfactant use, B, less oxygen exposure, C, fewer babies received surfactant within 3 hours of life, D, reduction of ventilatory need. I'm going to pause here for around 15 seconds, giving you the chance to choose the correct answer. Okay, so the correct answer from this study is B and D, less oxygen exposure and reduction of ventilatory needs. Second question, in studies use the lung ultrasound score as indicator for surfactant replacement in newborn with RDS. Which score was used as a cut level for surfactant administration? 7, more than 7, more than 8, more than 9, or more than 10? More than 8. So this is the correct answer. And this is the end of my presentation. Thank you and welcome for any questions. Thank you.